Hello, this video will provide an overview of the checklist to build trust, improve public health communication, and anticipate misinformation during public health emergencies, published by the Johns Hopkins Center for Health Security. This checklist, organized across 5 priority sections, provides evidence-based resources and tools to help health departments and other communicators to build trust in public health, improve public health communication, and anticipate challenges posed by misinformation during public health emergencies. There are 2 ways you can use this checklist. First, you can review the checklist contents pages, ticking the boxes next to the areas of strength for your organization and highlighting areas where your organization may be interested in additional guidance or tools. Then your organization can explore highlighted areas of interest. The other option is for readers to consider the checklist in its entirety. This video will discuss priorities 1, 2, and 3, while our part 2 video will discuss priorities 4 and 5. The first priority looks inward at organizational capacities like budget, workforce, and other administrative considerations, as well as review of the community's relationship with public health. The second priority describes how health departments can develop healthy and sustainable relationships with their communities. The third priority recommends ways that health departments can develop successful, equitable relationships with partners or otherwise leverage influencers in the community. By accomplishing the activities and tasks laid out in these 3 sections, health departments will lay a great foundation to execute the capacities and strategies in priorities 4 and 5, which are focused on anticipating threats to trust, as well as developing, tailoring, and evaluating public health messages.
Starting with priority 1, public health communication during emergencies is driven by its workforce. We recommend 3 tasks to take stock of your public health communication workforce assets, remedy gaps, and retain your workforce. First, health departments should identify the employees who engage in public health communication and list collective experience, expertise, and skills. For example, lived experiences similar to the communities you're trying to reach, prior experience in risk communications, subject matter expertise, specialty communication skills, foreign and accessible language skills, and community ties are often characteristics of a well-skilled public health communication workforce. If your organization decides that there are gaps in desired competencies or skill sets, we recommend some examples of how workforce gaps can be remedied through partnerships, trainings, or recruiting additional staff internally or externally. Finally, turnover has to be confronted. Turnover has a number of different causes, ranging from lack of competitive pay and burnout to harassment and violence against public health workers. We provide suggestions to deal with turnover, including implementing a harassment mitigation system, as well as cycling health department staff on and off public health communications during public health emergencies. Next, public health historically suffers from a lack of sustainable funding, often being subject to a feast or famine funding cycle between and during emergencies, respectively. We recommend 4 tasks to help maintain sustainable funding and other resource streams. First, we recommend creating a comprehensive multi-year view of all the funding that goes into public health communication, including during public health emergencies. Once that's done and gaps are identified, we present 5 potential solutions, including pulling resources with other budgets, exploring additional funding sources, advocating for increased funding, as well as relying on outside partnerships. The next 2 tasks are focused on dealing with the rapid, time-sensitive influxes of funding that can occur during public health emergencies. We recommend anticipating the situation and preparing accordingly by having clear plans to utilize large emergency disbursements and ways to sustain capacity building after funding dries up. Relatedly, we also recommend streamlining bureaucratic or administrative barriers that can impede funding access, if possible, like pre-planning memorandums of understanding or other contracts. Finally, it's important for communicators to remain familiar with their audience and their history with public health. We recommend that health departments review official data sources, engage in data collection, or work with community partners and community members to better understand who they're communicating to. We recommend also untangling the context behind varying trust levels in public health in the community, understanding that it's important to reckon with how distrust can manifest in different ways and be caused by differing factors.
Now it's time to start looking outward. In priority 2, we suggest steps to develop and maintain lasting relationships with your health department's community. These relationships can exist across a spectrum, from basic outreach to shared decision-making and empowerment, all depending on the needs and capabilities of the health department and the community. First, the health department needs to assess their buy-in, interests, resources, and priorities with regards to community engagement. The checklist provides a number of questions and examples of guiding principles that personnel can consider to kickstart this process, which in turn will inform the health department's community engagement goals. Next, we provide some recommendations for how public health personnel can maintain regular community involvement, which health departments can modify according to their abilities, interests, and feedback from community members. It is important to build in mechanisms to involve the community in public health decision-making, from defining public health problems together to finding ways that the public can contribute to potential solutions or advocate for themselves. If you want to get more formal with these processes, we recommend some resources for forming community advisory committees, performing robust community health needs assessments that feed into community health improvement plans, conducting community-based participatory research, and regularly engaging with community groups. Now, it's time to put these community suggestions and plans into practice, showing that your organization follows through. Even if your health department can't make large-scale changes, you can still show up in small ways. For example, regular, frequent public health communication activities outside of emergencies on topics of interest are valuable efforts. Reducing barriers to in-person engagement, like providing childcare during public health programs, can make community members more receptive to relationship building. For an even bigger impact, you can integrate community members even further by actively recruiting community members into the public health workforce, co-creating programs and strategies with community members, and integrating public health emergency preparedness and response activities with shared public health and community-based objectives. As you enact these recommendations, make sure that you do so in a sustainable manner with a clear way to evaluate progress and make changes accordingly. Check out this table for a summary.
Public health communication relies on messengers outside the health department, in addition to health department staff. In Priority 3, we discuss how these secondary messengers can be partnered with or otherwise leveraged. Just like in Priority 2, you're going to want to have a clear picture of your community's public health needs in order to have an idea of what kind of secondary messengers you want to reach out to and what exactly you'll need from them. For formal partnerships, there are a number of different ways to identify potential secondary messengers to work with. These are just a small selection of examples. These partners may be not-for-profit organizations with a public health focus, but they could also be individuals, businesses, government agencies, or other groups working in completely different sectors. Keep an open mind when considering partnerships. Then you'll want to take inventory of what the health department brings to the partnership, which may include financial support, health services at events, or other examples here. Next comes actually building the partnership. Reach out to potential partners and develop shared expectations on what you both want out of the relationship, the benefits you provide, and your ultimate goals for working together. Make sure you check in frequently and regularly and continually reevaluate how you can improve your partnership over time. There are several ways that partnerships with formal secondary messengers can improve public health communication, and this table includes some examples. A key benefit of these partnerships for health departments comes from your partner's ability to build trust, especially in low-trust communities, as well as their expertise with tailoring public health communication products and greater communication strategies. Try to involve them with as many stages of the message development process as possible, from rational for and decision-making around the choice to develop the message in the first place, to evaluating message effectiveness among community members. But what about other community influencers? Informal secondary messengers, which are people or groups that share health information without any formal agreement with a public health agency, can be incredibly useful and important in your messaging strategies. You first need to identify informal secondary messengers. You can use some of the same approaches you use to identify formal partners with some additional strategies, like opt-in text and email services that are more specific to finding informal secondary messengers. From there, the easiest way to have informal secondary messengers spread the health information you provide is through takeaway materials that they can share or impactful in-person conversations. Takeaway materials can include physical materials like flyers or virtual social media that can be easily forwarded and shared. Information from in-person conversations is more likely to be shared if there's a prolonged or regular interaction with health departments that influencers find helpful.
Thanks for watching. We would like to thank the research team and experts who have contributed to this work. You'll want to check out our Checklist Part 2 video, and don't forget to go to the Trust in Public Health website to learn more on these topics, including access to the full checklist report.